We have Dr. Satish Rao sir, who is attached to Birmingham Women and Children Hospital. He has special interest in difficult asthma, sleep, technology, dependent children, rare and orphan lung disease. He is the medical director for innovation and transformation, BWC Birmingham Soil Integrated Care Board. We also have Dr. N.K. Kalapanavar sir with us as the chairperson. He is the National President-elect IIP NRC 2024. He was a former medical director, professor and head of the Department Pediatrics, consultant pediatric pulmonologist, SS Institute of Medical Sciences and Research Center, Devangiri, Karnataka. He has special interest in pediatric pulmonology and critical care. He has received the Dr. Bhopi Best Paper Award, an invention of intraosseous needle. He has many publications in national and international journals. We also have Dr. B.A. Sharma sir with us. He is the professor and director of Pediatric Pulmonology Services, NAMES Medical College, Jaipur. He has special interest in pulmonology and sleep. He is the present president IIP NRC 2023. He was the past president IIP NRC Rajasthan chapter. He also had many national and international publications. I'd like to request the chairpersons to introduce the speakers. We have with us Dr. Julian Lake, Dr. Gary Connet, and Dr. Sushil Kabra as the speakers for this session. I'd like to request you all to please come up on the dais and take seats. I hand over the session to the chairpersons.
Thank you very much. Ladies and gentlemen, it's an absolute pleasure and honor to welcome you all to the first ever joint symposium between the Indian Academy of Pediatrics Respiratory Chapter and the British Pediatric Respiratory Society. I hope this is going to be a first of many symposia, and it is very exciting, this collaboration between the two great countries. It gives me great pleasure to welcome Julian, who is consultant respiratory pediatrician at Southampton. He is also the president of British Pediatric Respiratory Society. Cystic fibrosis is changing for good. The outlook is bright. So I hand over to you, Julian, to educate us more about the CFTR modulators. Thank you very much.
Thank you, Satish. Good afternoon, everyone, and thank you for the introduction, Satish. I'd just like to begin by thanking the organisers for inviting me to speak at this conference. And as president of the British Respiratory Society, it's a particular honour for me to actually be talking at what is the first symposium in combination with the IAP and NRC. And I'm hoping, as Satish has said, that we can move this forward and have many more collaborative sessions as time moves on. And I'd also like particularly to thank the hosts that we've had here. It's been absolutely fantastic. It's been a great meeting. And we've absolutely loved all of our time here in Calcutta. So what I've been asked to do today is to talk about some of the practical insights that we have and some real-world impact of CFTR modulators. Just to give a little bit of context, this is obviously a map of the UK, and we sit down here right on what is an occasionally sunny south coast. And what we live sort of 100 kilometres away, as you can see, from London. I suppose Southampton's famous really for the leaving of various ships, particularly the Mayflower and the Titanic. So this is the region where we work. So we are obviously in the Southampton, which is the centre, but we actually cover this entire region. And the region is about 26,000 square kilometres, which might mean nothing to you, but there's about 3.5 million people. And to give you some context, West Bengal has about 3 times the number of, it's about 3 times the size of Wessex, but actually has 25 times the population. So the population density is very low where we live. And the way we arrange our system is that we have a hub and spoke approach. So we sit at the centre here, but we then cover 9 hospitals in the Wessex region. They're centres that we visit to see the patients twice a year. And then we also look after the British Crown dependencies of Jersey and Guernsey, which are an additional 2 hospitals. So this is quite an old animation, and it's a little bit grainy, so forgive me. But actually, I think it really represents quite neatly the basic pathophysiology of cystic fibrosis. So we have the lipid bilayer, and then we have the chloride channel, which is the CFTR, or cystic fibrosis transmembrane regulator, and then we have the epithelial sodium channel, or the ENaC channel at the top. And what you can see in health, as I was showing you there, is that, I'll just go back and play it again. You can see that in the healthy situation, the chloride is passing through a healthy CFTR, and the CFTR has an inhibitory effect on the sodium channel. But in CF, what happens, chloride can't pass through, and the CFTR doesn't inhibit the ENaC channel, so this becomes overactive, taking water with it. And as a result of that, we lose the liquid layer which sits on the epithelial surface, and as a result of that, we no longer have the mucociliary escalator, and eventually, as a result of that, we get increase in secretions, and this becomes a nidus for infection and inflammation. So that's the basics of CF. But this, as we know, the CFTR needs to be abnormal in order for it to happen, and we now have over 2,000 different mutations that have been identified, and they've been grouped into 6 classes according to what the pathophysiology of that CFTR regulator is. And here we have, for example, class 2, where there is a problem with the folding, and as a result of the folding problem, it doesn't get up into the surface of the cell, so-called trafficking problem. And then we have this group 3, where it does get to the surface of the cell, but it doesn't function when it gets there. In the UK, Delta F508 is by far the most common mutation. About 91% of our patients will have at least one mutation. So these are the CFTR modulators, which modulate the CFTR to make it function better than it previously did. They're split into 3, so you have the production correctors, and these are an attempt to allow a read-through when there's a stop codon. Unfortunately, both of these agents haven't been successful thus far, although the ELX02 is still being trialed. Then you have the correctors, and these correct the CFTR protein folding, enable it to get to the surface, and then the potentiators, which, when the chloride channel is at the surface, they attach and actually essentially open the gate and allow chloride through. And these have been used in various combinations over the years. The combination I'm going to talk about in particular is the one that I've been asked specifically to talk about, is so-called ETI, which is a combination of elexacaftor, tezacaftor, and ivacaftor, and is variously named around the world, but for some unknown reason, it's Kaftrio in Europe and Trikafta in the US. But all of the trials with the ETI, or Trikafta, whatever you want to call it, have been in patients with a Delta F508 gene. So in an attempt to broaden the number of patients that can have the use of this drug, the FDA have produced this list of genotypes that may respond to the ETI, but this is based on in vitro data. This is quite a unique way of getting further patients onto it, because obviously you will have small numbers and wouldn't be able to do a controlled trial. So using in vitro data, they've broadened this. This is 178 different genes that they've extended it to. And in addition, there's further studies which are showing that this example is one from bioRxiv, which has just been put into onto the website. It's pre-publication, but it shows that of the 655 CFTR variants, a large number responded with over a 10% increase to ETI. And that's just the list of the ones they found. And then this is another quite novel way of approaching it, where you can use in vivo data. So in France, for example, you can use compassionate program in patients with advanced disease. And what they found is that about half of the patients they put onto it responded to ETI. And what they found was actually a lot of the 22 or 50% of them weren't on the FDA list, particularly N1303K. So this is another way of approaching this. Unfortunately, we don't have this available in the UK, although we are exploring the possibility of these trials. But talking about CFTR modulators, you would be not complete without what is this shocking and unacceptable fact that more than half of the estimated CF population in the world live in a country with no access to ETI. And as you can see, India is including in the red color, has no access to ETI. The blue color for Argentina is where they've actually made some legislative changes to enable patents to be used in order to get generic pharmaceutical companies to produce a generic form of ETI. But that hasn't happened anywhere else in the world at this stage. So moving on to our modulator use in the UK and Wessex. So it hasn't been plain sailing in the UK. I've just thought I'd do a quick timeline of how things have gone. So in June 2012, ivacaftor was first okayed by the EMA for G551D patients. And then in March of the next year, March 2013, we were allowed to prescribe that in the UK after review by NHS England. Then in 2014, a further 8 mutations were added for ivacaftor, and we were allowed to use ivacaftor for those. And then in November of 2015, the EMA granted a license to lumacaftor, ivacaftor, or Cambi for over 12s. And then started a long battle in order for us to try and prescribe that in the UK. And this resulted, it was a 4-year battle in total. And during this time, there was lots of advocacy from particularly the CF Trust, and there were many marches around the country. This is just one just in front of Buckingham Palace. As you can see, there was a big turnout. And there were some innovative attempts made by some of the patients. For example, a buyers club was started, and this was an attempt to bring people together to try and gain access to Orkambi via the route in Argentina. So this was started in 2019, and there were some visits made, and there were some drugs brought back. And during this time, the EMA had licensed lumacaftor, ivacaftor for 5 to 12-year-olds, and then later tezacaftor, ivacaftor for over 12s, or Symkevi. And then 4 years after it was first okayed by the EMA, and after all these battles that I've just described, eventually NHS England decided that Tez-Iva and Lumiva could be prescribed on a 2-year managed access program. In 2020, to our surprise, and this was right at the start of the pandemic, a deal was done between the NHS in England and Vertex to allow us to use ETI once we got a European license. So this is actually before the EMA had okayed it. And I must admit, it was a big shock to all of us. The license came in August, and we started prescribing in August of that year. And then further developments, in January 22, we were allowed to use it in patients between 6 and 12 years of age. We then got a license down to those who are over 1 for lumacaftor, ivacaftor, or Cambi, provided they had 2 delta F508 genes. And we are now awaiting, very soon, we are thinking we will get ETI for 2-year-olds and over. But then on to ETI itself, or Trikafta. So we know from many studies that it is a highly effective drug. This is just one presentation that was done at last year's North America conference. And what this shows is actually when you take a 3-year data in these patients, you see complete stabilization of the lung function. And as you can see with the sweat chloride, that also stays low. What we know is that from the initial trials is that when you start a patient on ETI, very rapidly you get about a 10% increase in your FEV1. and about a drop of 40 in your sweat chloride. That was also repeated in those patients that only had one delta F508. And the other thing we do know is that it's very well tolerated. Despite it being so effective, there's very few issues with side effects. This is just something in the over sixes, the trial in the over sixes, where there's an open label study for 2 years. And as you can see, there was about 130 or so patients, and very few needed to discontinue or interrupt. The reason for discontinuation in the parent study, so the first study, which was over 24 weeks, was for a rash, which on restarting, the rash came back. And then in the actual open label study, the reason for stopping that was that there was behavioral problems. So what is our experience? Well, we have 234 patients, of which 172 have used CFTR modulators. It hasn't been totally straightforward. We have had one patient with severe lung disease in which we had to do a dose reduction. We've interrupted doses because of jaundice and for raised liver functions, which we often see in patients when they're on ETI. We've had to interrupt one for behavioral concerns, one due to a rash, which didn't come back when we restarted the ETI. And then we stopped treatment in 3 patients due to psychiatric concerns. What I want to present is actually a little bit of data that we've drilled a little bit more into on 62 children that we've started on ETI. As you can see, it's a pretty much even split male-female. Mean age is 13.9 years when commencing the ETI. And we have 46 of them. So about 3/4 were actually homozygous delta F508. What we know from looking at, we have very clear records about whether they've had the drug delivered, because the drug has to be delivered directly to the home. So what we know is that our adherence, the proportion of days covered, was very high. As you can see, in the first year, it was about 94%, dropped a little bit in the second year, though it is surprising. You can see the range, there's somebody taking it only a fifth of the time, despite it being such an effective treatment. And then if you look at we've got some early experience with the 6 to 12-year-olds. What we see here is that there's sort of 2/3 male, again, about 80% with delta F5 are homozygous. One had to discontinue because of concerns about possible side effects. And then we had one who interrupted because of behavioral disturbance. So you can see there's a theme here with the psychiatric side of things. I just wanted to mention the CF Trust, and we have a great database where all of our, we input all of our 2 monthly clinic visits. And as a result, we get these sorts of plots every year, which just show where each center is. We're number 29, and as you can see, we're the 6th largest, but I think we're now the 5th largest because we've overtaken Leeds center in the UK. And this is before the start of using ETI. And as you can see, our median FEV1 at that stage was 98%. I think it was a little bit shocking a few years ago because there was some concern that the effects of these CFTR modulators might wear off. This is a study from Manchester, Peter Barry's group, and as you can see, there is a drop over 5 years back to the this was ivacaftor and G551D patients. But ivacaftor is essentially as effective as ETI, and so we were worried that might be potentially the case. But when we looked at our data, what we find is, as you can see, we get a 10% increase, and then in the ensuing 2 years, we do get a slight drop, but the rate of drop is significantly different to the 2 years prior to starting therapy. What is the explanation for that? Well, it may be that we're treating younger patients because it was adults that were being treated in Peter Barry's group. But the other thing is the adherence in our group was very high, as I've shown you earlier, so up to 90% even in the second year. In Peter Barry's study, what they found was that the adherence dropped very quickly and went well into the mid-80s by about year 4. This is just a little bit of data about our 6 to 11-year-olds, but as you can see, our percent predicted has remained high, with perhaps a little bit of a drop over the 12 months that we've been recording it. The other problem we have had is that we've noticed from our adult colleagues that patients start to gain weight at quite an alarming rate, and so obesity is potentially a big problem. As a result of that, we have changed our dietary practice, so we now are not advising fatty meals, we are advising a change to a healthy diet. And this is perhaps reflected in the fact that over the 2 years we do see a drop in our BMIs. But as I say, I'll move quickly now. Before we started, we had good BMIs anyway. What we have seen is a dramatic drop-off in the number of isolates, all significantly drop. We've also seen a major reduction, and this is probably the biggest thing we've seen, a major reduction in the number of intravenous treatments we need to give. We've been able to stop nebulized antibiotics because we're not seeing the organisms anymore, and we've only now got one patient on enteral feeding, having had 7 prior to this. I'll skip that. So our real-world experience, I think, is that in order to deliver this, it needs a fully committed team, and we need to adjust many of the things we were doing because things change dramatically when you're on ETI. We had to adapt because during this period COVID came and we were using a lot of different methods, particularly virtual consultations. It's a huge workload to start with. We have access to our regional clinic. We had to bring those in order for us to monitor the patients. And there are huge expectations both from the staff and from the parents, and those need to be managed. In some patients, you don't quite get the response that you would expect. So a few final thoughts. I think the biggest thing needs to be urgent action to provide global access to affordable CFTR modulated drugs. Maybe we can discuss that later. We don't quite know at the moment with ETI, because it's so effective, what the standards of care should be and what our patients should be on or not on. And we know that early treatment is like to have even more impact to prevent progression. This is just a quick glimpse of our team. All of this wouldn't happen without the team, although I have noticed that Professor Connor, he must have been away on another international conference or something when we took this, isn't in the picture. So thank you very much. That's great, and I'll take any questions.
Thank you, Julian. I don't know if Gary was on his travels around the world when that picture was taken, probably. Thank you very much for such a wonderful overview of the ETI specifically. So the floor is open for questions. I suppose just as people are thinking of questions to ask, I mean, can I... sorry, go on, Indu. Yeah.
You mentioned that you had to stop treatment because of some psychiatric manifestations. So what is the adverse effect of the drug, or because many of these children are anyway depressed as they grow older? So
yeah, I mean, that's a really good point. We think we think in each case it probably is the drug, and the main reason for that is that we quite rapidly, what the children realized, or well, young adults mainly, what they felt as soon as they started the treatment, they felt different in sort of 3 or 4 days. So what we have tried is various kind of low-dose schedules to gradually increase, but even that has failed in those patients because they're obviously very keen to be on this treatment. But yet we've not been able to restart in those 3 patients. Now, that doesn't mean we're not going to, and there are other drugs further down the line potentially we can use. But it does seem to be quite a rapid impact that it has on their psyche when they take it.
What kind of psychiatric side effects?
Well, most of it is low mood, okay. But just a change in the way they feel, I think. We have had one with suicidal ideation, for example, and obviously you have to stop then.
And you mentioned about obesity in these children who are on CFTR drugs. So do we monitor these children with like lipid profiles, etc., when we are on CFTR drugs? Is there a protocol to monitor their lipid profiles? HbA1c may not be the best parameter.
I must admit, we haven't. So the main thing we've been concentrating on actually is making sure that our BMIs in the clinic do not suddenly skyrocket. The biggest issue we've had is when you change the habits of the children, you need to change the habits of the parents because they very often go on to the same diet as the child. And the biggest difficulty we've had is actually convincing the parents not to eat fatty foods and crisps, etc., etc. So that's been a real issue. I know the adults are checking the lipid profiles. We think because we've put most of the children now onto healthy diets, we think we may have kind of got on top of that potential issue. But yes, it's a good thought. I mean, if we do have a child who is becoming particularly obese, then we would almost certainly, we have an obesity clinic where we would send the child and they would do the full workup, including lipid.
Thank you so much.
That's a good point.
I think we have one more question.
Sir, you have mentioned that you had to discontinue CFTR modulator in few patients. CF itself causes liver damage after a certain period of time. So how could you differentiate it was due to CFTR modulator or the CF itself?
So the question is, CF causes CF liver disease per se.
Yeah.
There were 2 children who were discontinued because of liver dysfunction. So how would we differentiate from a drug-induced versus CF-related?
Yeah, I think again it's quite interesting. So so what we tend to see is a transaminitis. So all the transaminases rise. In the trials, that happens as well. And so what we've seen with the children we have is that you go onto it. We're doing very regular monitoring of their blood tests every 3 months. And when they go onto it, it rises, it keeps rising. You keep an eye on it, it goes too high, then you stop it. And very quickly, because what we do is stop it and then get them back in a few weeks, it has dropped back to normal range. So I think there's no doubt that actually it causes the transaminitis. And it's been seen all the way through the testing and all the studies.
Okay, thank you, sir.
Thank you. There's one more question. Dr. Chu.
Yeah. We have very few patients on any of these medications. One liver disease patient who had enzymes in 2-3 times his normal values, he decided he has to take it, so in spite of our telling him caution is required, he did start. And his enzymes came down, he gained about 10 kilos in 3 months. He was 49 always, and he suddenly became 59. I don't know if that is a dramatic response is seen in some, or was this an exception?
Yeah, I mean, we have so each of the patients that's had a problem with their liver enzymes, we've desperately tried to put them back on. Most of them we've recontinued, in fact, because what we know is that if you start at a very low dose, you don't tend to see that going up. Now, in the studies, unless you were sort of 5 times the upper limit of the normal range, then you continued with the drug. So we tolerate very high levels of ALT and AST and leave them on it and just keep monitoring them, hoping. And in some, we have actually seen them come down as well with time. So I'm not sure he's particularly an exception with that. But so
another observation is that whatever the dose that we prescribe, they tend to take a lower dose, cost, supply, and so on being the reasons. And yet they seem to do fairly well. They seem to benefit out of it.
I think at a lower dose you still get a significant impact, actually.
Thank you.
So I can't see any more hands or any more questions. All it leaves me is to thank you, Julian, for kicking off the first ever symposium. So thank you very much.
Thank you very much.